This is Doctor Patient, a podcast that examines all the aspects of the patient-provider relationship. I'm your host, Heather Johnston, MD, a real-life doctor and patient. Today's episode is part 3 in a mini-series, or mini-drama I should call it, on racial disparities in healthcare. Episode 1 featured Linda Villarosa, a best-selling author on race and health, talking about her new book, Under the Skin, which basically traces the roots of many of today's racial inequities in healthcare directly back to slavery. Episode 2, we heard from children's author Michael Tyler, talking about a health episode he had in which his race directly impacted his healthcare and outcome. These first 2 episodes laid the groundwork to show you that this is a very real and very prevalent problem today, which really begs the question, what are we going to do about it? There are many, many, many folks working on just this question, and I can't really begin to do the topic justice. There are community-based organizations, doctor groups, patient groups, advocacy centers, politicians, and more, all working on trying to equalize the playing field when it comes to delivering fair and equitable healthcare to all. One approach is to think deeply about how we're teaching the next generation of doctors, specifically how we can relay these inequities to them and motivate them to start changing the system. I'm talking today to Dr. Patricia Poitevien, a senior associate dean of the medical school at Brown University. She has a fascinating, newish role there that she is taking on with gusto.
I am the Senior Associate Dean for Diversity, Equity, and Inclusion at the Warren Alpert Medical School of Brown University. This is a new role. It's inaugural. It started almost a year ago. April 1st of 2022 is when I took on this position. And although we had an office for diversity for many, many years, that was led by an associate dean, the original thought process or the original goal of the Office for Diversity was really to help support students who self-identified as underrepresented racially and ethnically, so a very specific sort of cohort of underrepresented students. The job of the office was to support them. And oftentimes what that meant was creating community, connecting students with mentors who were also from historically underrepresented groups. But it was a very insular office, right? It was an office created to help a very specific student population. And there are always going to be limitations with something like that because supporting students through a toxic environment can only get you so far. At some point, you have to look at the environment and you have to look at the systems and say, okay, we've been supporting the students through the toxic system for, a decade. How about we just change the system?
Brilliant. Take 2 steps back.
And so the creation of this position really had that sense in mind. It was, yes, we can continue to support students through an environment like academic medicine, which is not just toxic here at Brown. I would argue it's toxic everywhere around the country. Yes, we should continue to do that. And understand that we can't only support students because students become trainees and trainees become faculty. And so really we need to support all individuals, including nurses and other individuals who self-identify as underrepresented. We need to support this entire community of people. And while we're doing that, we also need to look systemically at how we can change the system so that we eventually make our job supporting individuals who are historically underrepresented obsolete, right? Like the goal should be the system is inclusive enough that everybody feels supported and no one needs an office for diversity because the system is here for everyone. And so in my role, I'm now doing both, like really expanding the support that we provide for individuals who are underrepresented beyond just students, and looking at the system to figure out how we can continue to make it more inclusive, really for everyone.
Mm-hmm. What are some of the steps you're taking on that latter point?
So as you can imagine, it's a pretty colossal endeavor. A big part of that certainly is education. And I think that's where Brown has had strengths for a really long time. We actually began to partner with our own Africana American Studies department on the undergraduate campus several years back to run courses on racism in medicine. And actually, one of the individuals who works in that department, Lundy Braun, is like the sort of expert on the history of pulmonary function tests and why there were different standards for pulmonary function tests for African Americans and for individuals who are white. She actually sort of spearheaded that research. She spent a good deal of her life lecturing about it and really tying together how specific events during our time of slavery have trickled down into how we continue to practice medicine. So she teaches 2 courses here for our students and also runs an elective course. And we have been doing that for a really, really long time. And so we're trying to expand on some of that initial work where it's important for us to talk about the historical nature of much of racism in medicine. But sometimes when we focus a ton on history, people presume that means that it's no longer relevant. It's something that happened in the past. It's not a part of who we are anymore. And so what we're trying to do now is really transition that historical context, which is critically important, but transition it to practical applications of what you are doing every single day. So how do you, as a provider of healthcare, question your positionality, your power, the differential outcomes that you see in your patients? How do you constantly keep that questioning attitude moving forward so that you can utilize the historical context that you learned, but also understand there's so much more to learn, right? Because this is a constantly evolving field. We are beginning to catch up with the content that we really need to understand in order to practice medicine in a way that's equitable.
What age medical students, what level of medical students take that course?
We have a course that we run. So Lundy's course, I'm pretty sure, is for the first year students, but then she runs an elective course for the second year students. We have a separate course that actually I teach called Racism in Medicine, and it just sort of goes through it's a very broad overview of how racism has impacted much of the medical information that we sort of take for granted, that we don't think about, that we don't question. And so I teach that as well, also to the first years. And so a ton of the content does come in the first and the second years. And that is very convenient because the first and second year students, as you know, are sitting in classrooms. And so a lot of it is didactic. Another project that I'm working on right now is the creation of a third-year clerkship on racism in medicine. Because really, if you think about the model of medical education, we do all this preclinical stuff, right? The first 18 to 24 months of medical school. And then we send our students out into clinical spaces and we say, now it's time for you to learn the practical application of everything that we taught you. But we don't do that with racism, right? So again, it kind of goes back to this. I can teach you a ton of content on racism in medicine, but what I really need you to do is take that content and make a difference. And so, some of the skill building that we want to teach our students is how to engage in a conversation about race with a family, particularly if you're in a non-race concordant relationship with that family. We know that in pediatrics, for example, we know that racism is a significant ACE. So how do you engage in a conversation with a family about how racism is impacting them, how it might be impacting their children or their other family members? And how do you do that in a way that is helpful and supportive to the patient and helps to see them for who they are? So I think that skill building around the context of the history of racism is our way of saying, okay, this is how you show up and bring this knowledge into your exam room every single day.
Mm-hmm. Is there any kind of self-reflection component early on in the first, second year, or later on, third, fourth year, or even into residency where they look back and I don't know how many years you've been doing the program, but have you gotten feedback about it? So
for the third year clerkship, we're still building it. So we haven't gotten any feedback. One of the pieces of the clerkship is like self-reflection, and it's consistent self-reflection that they have to review with the leader of the clerkship. Because, I don't need to tell you or this audience that racism there's so much about it that is personal, and come into this work with entirely heterogeneous levels of engagement with racism, right? Like you have someone like myself. I was actually reflecting on this in a group of faculty members, faculty leaders, and I was the only Black person in the group. And I said, you have people like myself who, for personal and for professional reasons, I think about racism every single day. Like I can't remember 24 hours that have passed, I don't know, in the last 2 decades of my life where I have not actively thought about racism, right? So that's one end of the spectrum. And then you have individuals who, for personal reasons and for professional reasons, might not ever consider the impact of racism, or they might only think about it when they're in a conversation like the one that we're having now or in a training session. So when you have individuals at those two ends of the spectrum, and we definitely have students who are at those two opposite ends of the spectrum, making sure that there's some self-reflection to understand how our personal identities and how our own personal histories and experiences influence how we show up in exam rooms for patients is critical. Because if we're not examining that, then we're completely missing the boat. Like we're not all coming into this conversation at the same level.
Are you aware of anyone else doing programs like that, creating clerkships around the idea of racism in health and health disparities?
I actually don't. I've been looking because it's like, why reinvent the wheel if people are doing this well, or maybe find ways to collaborate so that one person, one school's approach might be different than the approach that we're taking, and we can learn from one another from those different approaches. One of the challenges, well, we have several challenges in rolling this out, but one of them is, how do you assess a student who's gone through this clerkship? Like, what does it mean? In everything that we do, our goal is that our students are learning something and growing. And so how do you assess whether someone has, really understood the information that's been shared with them, and that the information has been transformational, right? Like, we have simple goals and objectives for the clerkship, which we always have for clerkships, but they don't feel meaningful, right? Like, of course, we want you to understand the impact of racism. Yes. But really, I want to transform how you think about your interactions with people. That's really hard to measure. So trying to understand how successful the clerkship is going to be, because we want to measure the outcomes of the clerkship, is someplace where I get tripped up quite a bit. It's like, how do we think about assessment outside of our traditional measures of assessment in order to capture what it is that we think is really important about an educational exercise like this. That part is a little bit tricky.
Yeah, when I was at U of C, I taught a lot of the courses on professionalism. And, how do you teach someone to be more professional in their relationships? This conversation is making me think back to that. Also, my anxiety's going up a little bit. But I remember we would have the same conversations, and this was back in 2003, 2005, we were having these conversations like, well, what does it mean that the student has learned it or not learned it? And we ended up just basing a lot of it on self-reflection. We felt like if they were able to be very self-reflective on some of their experiences that they were having, that was a very good sign that they were just at least learning, that at least they were demonstrating that they learned a skill that over time then should help them achieve the goals we were trying to teach. Yeah, that is.
The more, so I've done a ton, as you can imagine, in this role, and just because of my own interest, I've taken a lot of time to learn more about what it means to be anti-racist and anti-oppressive in an academic environment. And what I have come to understand is just how academia itself is an oppressive environment. And so the tools that we utilize to measure success within academia are oppressive by nature. There's an entire concept of epistemic injustice, which I was not familiar with before I started this work. And the idea is that our entire understanding of higher education is really baked in oppression, right? Because the individuals who created structures of higher education were mainly European, white men. And so the structure that they built was a structure that reflected their values. And so we continue to function within that structure, of course, but it also behooves us to question all of the parts of that system if our goal is to dismantle oppression. Right? So, you think about assessment, for example, right? Like how we assess competency. And a big part of assessment in competency in medicine is, standardized tests around medical knowledge. And, I see you nodding your head, so you know exactly where I'm going with this, right?
Yep.
But have we ever demonstrated that individuals who demonstrate a better sort of, I don't want to say a better grasp, but a better ability to recreate or reproduce their understanding of medical knowledge on a standardized test, have we ever demonstrated that those people are better doctors, provide better care?
I'm sure not, but also that's tricky because what does better care mean? How would you even begin to measure?
Heather, we are on the same path, right? Yeah. So it's literally, it's like you just start deconstructing all of these things that you've always taken for granted. Like someone might say better care is better outcomes, right? And I think a lot of individuals think that way. It's like if a patient does well, you have given good care, right? Like when you talk to patients, and you said this right before we started this interview, they might say actually the relationship that they have with their doctor is the sign of the best care. And it's not their outcome, it's their ability to talk to their doctor, confide in their doctor, trust what their doctor has to say. And are we measuring any of those things when we're measuring competency in medical school? And do we even know how to measure for another phenotype of individual? Because if I don't have a way of measuring how well you communicate or how well you develop a relationship of trust with another human being, how can I make sure I'm selecting for those people? There's no way for me to do it. I'm looking at your grades. I'm looking at your MCAT score. And then I'm looking at an interview with who? With a lot of other people who are entrenched in our older system, who are not asking themselves those questions. And so that system is going to recreate and reproduce the exact type of physician that it's always recreated and reproduced.
It makes me wonder if the current changes in the college admissions landscape, this is on my mind because I have one in college and one heading to college soon. It makes me wonder if the makeup, of the more competitive colleges, as it's changing so much now, partly because of the pandemic, but also because I think a lot of the schools just glommed onto the pandemic as an excuse to make changes that I think are right. Less legacy admissions, more diverse admissions, test blind, test optional, non-testing. I love all of that. It did not help my white Midwestern children, but I'm cool with that because I think it's better for the world. But it makes me wonder if then, those students are then going to feed into the medical school system, and it makes me wonder how that's going to change down the line.
I mean, I'm hopeful that it does change. The problem is, and I try not to always think about problems.
That's partly your job.
Part of my job. The problem is that you can feed all of these diverse individuals with different perspectives and different skill sets into our system. But if we don't fundamentally change our system, they will either fundamentally change because you adapt to the system that you're in for survival, or you leave.
Oh, that would be terrible.
Right? Yeah. Or you're out. And what we have found is that certainly individuals who are at least of diverse identities, right? When they come into our system, we fail them. And I mean, not like we give them an F, but we do not create environments that are inclusive. We do not create environments that encourage belonging. And we do not create environments that encourage their success. So either they leave, they're dismissed, or they fundamentally try to change who they are in order to survive in the system. And the whole reason why we brought them in, which was for their diverse perspective and their diverse background and their different way of thinking about things, gets lost because the system itself works to dilute it out, right? Like if you think about medical education, our medical education system is all about uniformity. We don't have a system, and you could argue that's sort of like all of education in the United States, right? But I'm just going to focus on medical education because that's my area of expertise. We really focus on uniformity. We're not trying to celebrate diverse perspectives. Like there is a way that you do things, right? We talk about clinical practice guidelines and we talk about uniformity in outcomes. And there's a very specific definition of a doctor that we have in mind. And we try to fit everybody within that definition. Now, I'm not saying that that's fundamentally wrong because we do have to have standards, right? Like we have to have standards for what we think make a successful physician. And we have to be careful that in the support of those standards, or even in the replication of those standards, what we're not doing is eliminating opportunities for different perspectives and different thoughts and innovation, frankly. And I think that's always the danger with any of these large institutions, right? Like you say there's a standard for a physician that we want, and you create that standard, and that feels like it makes sense. You want someone who has a minimum amount of understanding about X and a minimum number of years in training around Y and a minimum number of patient experiences. Totally makes sense. But what else are we selecting for when we create those systems? There are other aspects that we're selecting for that I don't think we're always conscious of. We dismiss the things that we claim to celebrate. Because if a student comes on a clinical rotation and is rounding with us and they say something that is different than what the attending thinks, depending on the psychological safety of that group, the attending might just shut them down. Like medicine is still based in a hierarchy. So how do you encourage innovation and diverse thought when there's a person in charge who gets to make all of the decisions, and then their residents and their students, and sadly, then their nurses and our interprofessional care team? And we have this hierarchy that we actually worked really hard to maintain, but then we say that we really want diversity and innovation and, like different ways of thought, but those two things don't work together. So one has to be dismantled in order to welcome the other one.
It's almost a little dizzying because you have to work forwards and backwards at the same time. Like, the students are coming in, you have to think about who you're selecting, what your makeup is, what your goals are for them right from the start. But at the same time, you need to be at the end point and say, well, what as an institution are we going to say defines a good doctor who can graduate from here? Do we just want someone with the good test scores, or do we want somebody who shows empathy in the face of difficulty and pressure and is inclusive of all of their patients? And then you have to say, well, okay, now we have the definition of the doctor that we want. We have to work backwards to create the curriculum. That's very dizzying.
And it's particularly hard to do because there's a lot invested in the current definition of doctor, right? So all of the people who are in charge worked through the current definition of doctor, including myself. And so to question our current definition is to question the identity of all of the people who are in charge. And some people are okay with that, and some people absolutely are not.
Yes.
And it really threatens who they are and their core identity, and they're not comfortable with that. Because if I did it one way, if I became a doctor because of this very specific skill set, if I scored awesome on my MCATs and fantastic on my STEP and blew my board exams out of the water and published the way I was supposed to, which is what everybody told me to do, then why do we get to change the rules now? Because that's what I did. And if you're telling me that what I did is not what makes a good doctor, then you are de facto telling me I'm not a good doctor. People do not like that. And in the end, of course, we're not telling people that they're not good doctors now because they went through another system. What we're saying is that we have opportunities to bring in other people who can also be good doctors, right? Like, it's not a zero-sum game. A lot of equity talk is around, we don't all work with one pie, right? Like, it's not, if I get a slice, you don't get a slice. you are a good doctor. You've accomplished a lot. That doesn't mean that how we define doctor needs to stay the same in order to maintain your value as a human being and as a physician, right? Like, it's not a pie. This is both and. We can bring other people with other skill sets into this space who can also be exceptional physicians, and that doesn't have to threaten who you are as a person.
Let's play fantasy for a minute. Pretend we live in a world where, well, this might not be fantasy. I'm not dinging you in any way. Let's pretend, let's say future instead of fantasy. When you personally develop an incredible curriculum that just works right for everyone around this topic, could you see something like that being able to be plucked out and used at other medical schools? I think, just to restate my question more clearly, could you ever see there being a national curriculum for medical students on these ideas that all the schools could use?
Absolutely. Absolutely. And I think that there are some spaces where we're thinking about this on a more sort of national or even like global level. So I'm going to do a little bit, it's not really self-promotion, but the American Board of Pediatrics actually put together a small working group, I want to say about 2 years ago, and I had a chance to serve on the working group to look at entrustable professional activities. You may or may not know, entrustable professional activities are another way that we are trying to get a better sense of the competency of our pediatric trainees, right? It's like, and we're doing this in pediatrics, but the boards for all of the other specialties are also doing something very similar, right? There's recognition that how we've assessed competency of our physicians is not perfect. And entrustable professional activities are really based in competency-based medical education. It's like, how do we make sure that the education that we're providing is linked back to the competencies that we want physicians to have? Which, as we shared in the beginning of this conversation, has not always been the case, right? Like, how we assess our doctors has not always been linked to the competencies that we actually want them to have as doctors.
Yes.
Which is like a crazy concept. Sometimes I say that out loud and people look at me like I'm crazy. I'm like, no, seriously. Like, I'm not even kidding.
You're not crazy.
And so we have 17 entrustable professional activities in pediatrics. And one of them was an entrustable professional activity on like quality improvement and advocacy. And the working group was actually charged with incorporating anti-racism into the entrustable professional activity. So that not only were we calling out what we wanted pediatricians to understand about how race impacts pediatric health outcomes, we also had to call out how those things were going to be assessed. And the EPA is meant not only for residents, the EPA is ultimately meant to help to measure the competency of all physicians. And so that to me is a very sort of global perspective, like no matter where you trained as a pediatric resident, we, the board, expects you to have some level of competency in how racism impacts your patients, how to measure how racism is impacting your patients, and how to implement systems to help mitigate the impact that racism has on your patients, which is like kind of revolutionary.
It is. I'm. My mind is working. That's why I'm looking at you blankly. I'm like thinking about 100 things at the same time. So is the idea here that if the American Board of Pediatrics comes out and says, for example, we expect our physicians to demonstrate competency in terms of racially sensitive relationships with their patients, then that will drive medical schools to be required to teach it?
Well, certainly, because the board is really looking at the competency of residents, it will at least drive residency education. And we actually do a ton, in addition to just creating the EPA. Right. We also talk about like, here's curriculum that you can utilize to help support what we're saying we want your residents to be able to do, right? We don't want to just put the requirement out there. We also want to give people the content that they can deliver to their trainees. But as you can imagine, anti-racism in pediatrics is not that different than anti-racism in adult medicine or in gynecological care or in surgical medicine, right? The concepts are the same. how you might execute or assess it might be slightly different based on your specialty, but overall, we're asking you to do the same thing. We're asking you to have an understanding of how racism impacts medicine. We're asking you to have a questioning attitude so that you can interrogate your systems for how racism is impacting your systems. And then we're asking for you to then help to recreate systems or to mitigate systems where you're seeing how racism is impacting your patient outcomes. And even though that might change a little bit based on specialty, it's kind of the same thing. And you can pull it back to medical student education as well. Absolutely.
But you were talking about just the wide variety of preceptors and teachers that you have who then become responsible to teach this material. I wondered if you have a program in place to teach the teachers.
Absolutely. We actually do a ton of faculty development. Some of it is proactive. Some of it is reactive. So I'll explain that a little bit. Right now, for example, we actually this past year hired outside consultants because we don't have enough people with fluency in how to teach in an anti-racist way. We just don't have enough of those people within our institution. So we asked a group to come and help our faculty members again, understand the complexity of racism. Racism and oppression in general is really complex. People spend their entire lives studying this, writing about it, lecturing on it. And our faculty members are busy people. They're seeing patients, they're teaching. So we can't have an expectation that they too would have this level of expertise just magically. And so we hired some individuals who are doing anti-racism workshops with our faculty right now to give them some of that skill set. So that's some of the proactive work that we're doing. And then the reactive work that we do, and I think it's important that you have both, is that we also have a system to report what we call curricular opportunities. So when our faculty members are sharing clinical content, particularly in the preclinical years, but also in the clinical years, when they are sharing curricular content that might be based in oppression or might not be inclusive and sensitive to different identities, our students have the ability to report those, and we call them curricular opportunities. Those actually are all reviewed by someone who is incredibly talented here, our assistant dean for diverse curriculum, teaching, and learning. She's a PhD in anti-racism education. She's not a physician. And she reviews all of the curricular opportunities and then creates sort of like individual plans for those faculty members based on the report. So sometimes it's just that the dermatology lecture did not have enough representation of rashes on different skin tones. And so she goes back to the faculty member and she says, here are some resources. Can you please, create some more slides so that individuals can see these different pathologies on different skin tone, right? Like that's not hard. Right. Sometimes it's in something that a faculty member has said. So the slide is fine and the content is fine, but how they delivered the content was not inclusive. So one of the other examples that we hear a lot is a faculty member that might speak about prevalence related to race as opposed to related to racism, right? So you say that Black individuals have a higher or I'll use another example. You say Native American individuals have a higher incidence of alcoholism, and then you end the conversation and then you move on without ever really explaining that it's not something inherent to individuals who are American Indian or Native American. It's actually related to racism and systemic oppression. So it's like, okay, faculty member, we're going to need you to elaborate a little bit more about why you see the statistical difference and have some more content expertise and how racism has played a role here. So that the takeaway message is not that this is an inherent part of this person's racial biology or whatever that is, but that this is really an impact of the system. It takes a lot of work.
Yeah, I'm so excited you have that person. I wonder how many schools have someone like that role specifically. I mean, I've never heard of it.
I don't think very many, to be honest with you. Our team, I think I was sharing at the beginning, our office started as this really small office, like just to support students of color. So there were a total of 3.5 FTE, right? Like for the entire office. Mm-hmm. In the year that I've been here, we have exploded the office because a lot of work needs to get done. And we went from 3.5 FTE to we have 12 individuals now in our group, and altogether there are about 9 FTE with like everybody's work. And I feel very privileged to be able to do this work in this environment with this level of support. I know not everybody has that. So our goal, of course, is to export as much of this as possible so that even in lower resource settings, we're still getting the students and the trainees and the faculty the education that they need.
I love it. I'm so glad you're there. I'm so glad you have that job and that you're there. Oh man, makes me feel like it's going to be okay. Pat, it's been so great talking to you. I've learned so much about what you're doing there.
This was a lot of fun. I've been in different interviews before, and this really did not feel like an interview. It felt like I was talking to a friend of Barrett. So thank you for creating that environment.
People who care about the same stuff, you know.
But I really appreciate you elevating it on your own platform and bringing such different perspectives to the table, and just your general treatment of the topic has been amazing. So I'm really appreciative of you. Thank you.
You're very welcome. I think one of the most important things Dr. Poitevien brought up in our interview was looking at the medical education system big picture. I agree with her that at most schools, the system today is not too different than the system it was decades ago in terms of what kind of metrics are used to select candidate students, and then also what kind of metrics are used to assess their performance, things like competency on exams and proficiency with certain doctor skills. It's hard to know which prospective students will be compassionate, empathetic, trustworthy, and sensitive to racial and ethnic differences with both their patients and their healthcare community. It's hard to even know which admitted students are good at that, because at many medical schools, those qualities, while maybe viewed as important, are not actually assessed. As students climb in rank, they spend more and more of their time with patients one-on-one, so no one's really observing in depth how they are with them. I propose that more patient feedback be used in medical schools to assess the students and residents for those unmeasurable qualities. After all, the patients are the ones who are receiving the care from them. Maybe it could be like when my kid got a driver's license. He needed me to sign off on 50 hours of competent driving. So the med student could have a card that requires 30 or 40 patients to review them personally. I love coming up with ideas that I hope someone else will implement someday. Stay tuned for more idea generating in the coming weeks. Thanks for listening today. To catch up on more episodes and to get new ones delivered directly to you, subscribe wherever you find your podcasts: Apple, Google, Spotify, iHeartRadio, and more. If you'd like to be a guest or have an idea for an episode, let me know at www.drpatientpodcast.com. That's drpatientpodcast.com. Here's the disclaimer. Even though I am a doctor, I'm not your doctor. These stories, my comments, and all discussion is purely reflection about what's working in the healthcare system and what isn't. Don't use any medical information that you hear in these episodes to diagnose or treat yourself. If you have a question about your health, get in touch with your doctor or local health clinic.